by Dr. Tin that it should be over in 1 minute, sorry, 5 minutes. So Joel is a 1.5-year-old child. Can I quickly run the PowerPoint?
1 year, 10-month-old baby diagnosed to have a large malign subpulmonary ventricular septal defect with posteriorly deviated conal septum, small aortic annulus, and interrupted aortic arch. He underwent a SVE procedure in July 2017, that is bovine pericardial patch closure of the VSD, tunneling the native pulmonary valve and the aortic valve into the LV, interrupted aortic arch repair, transaction of the main pulmonary artery before the branching and attaching the distal end to the undersurface of the arch, RB2PA bovine pericardial conduit. In the intraoperative period, the LAD was found to be originating from the RCA. On follow-up, noted to have progressive increase in gradient across the RB2PA conduit. He has significant growth failure. On examination, weight is 9 kg as expected against 12 kg. Pulse rate around 110 per minute. BP is 90/60. SpO2 90%. 4/6 ejection stalling murmur on the left sternal border.
Want this.
Chest is shows cytocervical liver cardia, right atrial enlargement, pulmonary oligamia. ECG shows PR interval 120 millisecond RVH.
Show the CT scan.
This is the CT pulmonary angio showing the discrete narrowing.
So you can see that the CT is showing a tight conduit stenosis. Basically, the bovine pericardial valve that is inside has become rigid. Show the previous picture, which is like a shelf. It is protruding from the superior end, and that is causing a tight narrowing. And the RV systolic pressure was 40 more than the aortic pressure. And in that short axis, show back. The circle that you are seeing in the middle is the aorta, and the hugely dilated next vessel is the pulmonary artery. Both this aorta and pulmonary artery are now connected to the left ventricle. That is the SVE procedure, where the left ventricle has two exits. One is the native aortic valve and one is the pulmonary valve. And through that, both is finally connected to the arch of the aorta, and it comes down as the descending aorta. Now the problem that in this patient, can you show the coronary? The coronary arises from the RCA, courses anterior to the main pulmonary artery, and then dips behind the conduit and courses towards the left anterior descending groove. You can see in this picture the large conduit, which is proximal conduit is 14, distal conduit is 17, and the severely narrowed obstruction. And you can see the left anterior descending coming from the aortic root, coursing broadly in front of the pulmonary valve, and then dipping behind the conduit. Next picture. So this is the conduit with the narrowing, and the other picture is the relation. The pink one is the left ventricle and the brown one is the right ventricle. So what we did today morning, like right now, was show the first picture. So this is we checked the gradient between the ascending aorta and the femoral artery. There was no gradient. This is the catheter that went into the pulmonary outflow tract. So this pulmonary outflow tract is now a competent pulmonary valve. It is like a stand cell anastomosis. Next picture. So this is the native aortic root. So the native aortic root shows the right coronary. Freeze it. Freeze it. Yeah. So the right coronary gives off the LAD, which is coursing below the circumflex and going all the way down. Keep running. So that is the LAD. Next picture. So then we did the conduit angiogram. We found the shelf-like obstruction. Freeze it. So that is the shelf-like obstruction from the top. The hemodynamics RV was 140 when the aorta was 100. The distal pulmonary artery was 25. Next picture. Yeah, balloon interrogation of the this is Cook Formula's stents 10 millimeter balloon. Because we wanted a completely a balloon which will widen out to full 10 millimeter rather than like a Ty-Shak 2 balloon which might be constrained partially. Next picture. So then after this we have advanced the sheath inside. Our intention is to stent the conduit using a 10 mm or maybe a 12 mm formula stent. It's a 1.5-year-old child weighing 9 kilogram. No. I'm going live now. So what is that? Sure. Just one question. You want a 10 mm diameter, or would you want a 12 millimeter balloon mounted with this 10 mm stent? Like finally getting it up to 12. Okay. So I will take out the stent from the formula and deploy it on a 12 balloon and then deploy. Yeah, I will record. Thank you. Yeah. Sure. So this is the place where we left. This is the balloon occlusion, and with the balloon interrogation we can identify that aberrant left anterior descending is filling well. Next picture. So we decided to choose a 12 millimeter opta balloon, OPTA cordis, on and we mounted the formula stent on the 12x2, and next picture. We found that the balloon alone was entering the sheath because the stent was caught in the check flow valve of the flexor sheath. So then subsequently we got it rectified. We inflated the balloon a little bit to grip it, and this is the stent. This is a 12 millimeter into 2 centimeter opta balloon with the formula 20 millimeter long. So this is the lateral view angiogram. Our concern here was the coronary that was crossing. Next picture. So this was the positioning of the stent. Here the positioning seemed to be good, but when we did the coronary angiography, next picture, we found that the aberrant LAD was just coming near the proximal end of the stent. So we pushed the stent marginally inside. Next. So we repeated. So now we are a millimeter above the coronary artery. Then next picture. So we repeated whether we are safe on the conduit. We found that our proximal end is matching the stenotic segment. Next. So then we expanded the stent with a gentle forward push so that the stent does not come back and hitch against the coronary. Next picture. So then we rechecked. The coronary that was crossing anteriorly was intact. So then the distal end of the stent got deployed to 12 millimeter, but the proximal end was still 10 millimeter. Next. So we reinflated the proximal end to again 12 millimeter. So this is the proximal end going to the same 12. And then the next picture. So this is the coronary. The coronary was looking fine. And is that the last? Yeah. So the RV pressure at this point is 35 millimeters of mercury. The sheath is in the right ventricle. That is 32 millimeters. It has come down from 140 to 32. And the aortic pressures are around 110 plus. Okay. Okay. Come. No, I will do it right away. The catheter is inside. Come to AP view. Now it was showing very clearly, Shaq, here. In this picture, we can see the whole coronary coming anterior to the pulmonary artery, going posterior and descending as the LAD. Cranial. Yeah. Yeah. Can we inject? Yeah. Freeze it and show that LAD. Yeah. The second vessel is the LAD. So thanks a lot for giving us this opportunity, and We wish you a very good, fruitful gala dinner today, and a good day tomorrow also. Thanks to Dr. Tin for the opportunity.